Welcome to our discussion on neurologic emergencies. The brain is an incredibly complex organ that controls all bodily functions, including movement, thought, sensation, and consciousness. As EMTs, we must be able to recognize neurologic emergencies quickly and understand how to manage them in the pre-hospital setting. In this lesson, we'll cover the anatomy and physiology of the nervous system, common neurologic conditions, and how to assess and treat these patients effectively. The brain can be thought of as the body's computer. It processes information, coordinates responses, and ensures that vital functions continue uninterrupted. It consists of three major parts: the cerebrum, the cerebellum, and the brainstem. The cerebrum is the largest portion, responsible for higher cognitive functions like memory, emotions, and voluntary movements. Here, we see an illustration of the brain, which is well protected by the skull. The major parts of the brain, the cerebrum, cerebellum, and brainstem, each have distinct functions that are vital for life and movement. As EMTs, we must understand these structures to recognize deficits that indicate serious neurologic conditions. The brainstem is the control center for the body's most essential functions, such as breathing, blood pressure regulation, swallowing, and pupil constriction. The cerebellum, located at the base of the brain, plays a crucial role in muscle coordination, balance, and fine motor control. The cerebrum is divided into right and left hemispheres, each controlling the opposite side of the body. The frontal lobe governs emotions and thought, the middle section manages sensation and movement, and the back portion processes vision. Damage to specific regions of the cerebrum can result in profound deficits. Speech is primarily controlled in the left hemisphere of the brain, particularly in the area near the middle of the cerebrum. The brain communicates with the rest of the body through a network of nerves, including 12 cranial nerves that directly extend from the brain to the head, face, and neck. Beyond the cranial nerves, the remaining nerves of the body originate from the spinal cord. The spinal cord exits the skull through an opening called the foramen magnum and extends down the vertebral column. At each vertebra, two spinal nerves branch out, carrying motor and sensory signals between the brain and the body. This image illustrates the spinal cord, which continues from the brainstem and extends to the second lumbar vertebra. The spinal cord is crucial for transmitting information to and from the brain, and injuries to this structure can result in significant impairment or paralysis. Neurologic disorders can disrupt normal brain function, affecting consciousness, speech, muscle control, and sensation. The brain is highly sensitive to changes in oxygen levels, glucose supply, and temperature. Any alteration in these factors can have significant effects on a patient's neurologic status. Headaches are one of the most common medical complaints. While most headaches are benign and do not require emergency intervention, some can indicate serious underlying conditions. It's important to recognize the different types of headaches and identify when immediate medical care is needed. Tension headaches are the most common type and are caused by muscle contractions in the head and neck. Stress is a frequent trigger. Patients often describe the pain as a dull, squeezing sensation or a persistent ache. These headaches typically resolve without medical intervention. Migraine headaches are thought to result from changes in the size of blood vessels at the base of the brain. The pain is often described as pounding or throbbing and is frequently accompanied by nausea, vomiting, and visual disturbances. Migraines can last for hours or even days. Sinus headaches occur due to fluid buildup in the sinus cavities, leading to increased pressure and pain. These headaches are often associated with congestion, coughing, and fever. Unlike migraines and tension headaches, sinus headaches typically resolve with decongestants or antihistamines. While most headaches are not life-threatening, some can indicate serious conditions such as hemorrhagic stroke, brain tumors, or meningitis. If a patient presents with a sudden, severe headache accompanied by neurological symptoms, it should be treated as a potential emergency. A stroke, or cerebrovascular accident, CVA, occurs when blood flow to an area of the brain is interrupted, causing brain cells to die. This can result in permanent disability or death. There are two main types of strokes: ischemic, which is caused by a blockage, and hemorrhagic, which is caused by bleeding in the brain. Ischemic strokes are the most common, accounting for approximately 87% of all strokes. They occur when a blood clot or embolus blocks blood flow to a portion of the brain. The severity of symptoms can vary greatly, from subtle weakness or difficulty speaking to complete paralysis. These strokes are often caused by atherosclerosis, where fatty deposits build up in the arteries, narrowing the blood vessels and increasing the risk of clot formation. This image illustrates how atherosclerosis can lead to ischemic stroke. When an artery supplying the brain becomes narrowed or blocked, brain cells in that region begin to die due to lack of oxygen. Rapid recognition and treatment are critical to restoring blood flow and minimizing long-term damage. As EMTs, identifying stroke symptoms early and transporting the patient to an appropriate facility can significantly improve outcomes. A hemorrhagic stroke occurs when a blood vessel in the brain ruptures, causing bleeding into the brain tissue. Although less common than ischemic strokes, hemorrhagic strokes are often more severe and have a higher fatality rate. Risk factors include chronic hypertension, stress, and strenuous activity. Patients with extremely high blood pressure are at the greatest risk of experiencing a hemorrhagic stroke. Aneurysms are one of the primary causes of hemorrhagic stroke. An aneurysm occurs when a weakened section of an artery swells or bulges, increasing the risk of rupture. If an aneurysm bursts, blood spills into the brain, leading to severe neurological deficits or death. Patients may describe a sudden, intense headache, often referred to as a thunderclap headache, which requires immediate medical attention. A transient ischemic attack, or TIA, is often called a mini-stroke because it causes stroke-like symptoms that resolve within 24 hours. Unlike a true stroke, a TIA does not cause permanent brain damage, but it serves as a warning sign that a full-blown stroke may be imminent. About 1/3 of patients who experience a TIA will have a major stroke in the future, making early recognition and medical follow-up essential. Stroke symptoms can present in various ways, depending on which part of the brain is affected. Common signs include facial drooping, sudden weakness or numbness in one arm or leg, and loss of sensation or movement on one side of the body. Some patients experience a loss of coordination, known as ataxia, or a sudden difficulty with balance. Visual disturbances are also common in stroke patients. They may experience sudden blindness in one eye, blurred vision, or double vision. Difficulty swallowing, a decreased level of responsiveness, and speech impairments are also warning signs. As an EMT, it's crucial to assess these symptoms quickly using standardized stroke assessment tools. Patients experiencing a stroke may develop aphasia, a condition that impairs their ability to understand or produce speech. They may also have slurred speech, known as dysarthria. In some cases, a stroke presents with a sudden, severe headache, confusion, or dizziness. Recognizing these signs early allows for faster intervention and better patient outcomes. Other possible symptoms include muscle weakness, restlessness, combativeness, tongue deviation, or even coma in severe cases. Some patients may not recognize that they are experiencing a stroke, making bystander reports and thorough assessment critical. Rapid transport to a stroke center can be life-saving. When a stroke occurs in the left hemisphere of the brain, it often affects speech and language processing. Patients may struggle to form words or understand spoken language, a condition known as aphasia. Additionally, left hemisphere strokes frequently result in right-sided weakness or paralysis. Identifying these deficits can help pinpoint the location of the stroke. A stroke in the right hemisphere typically causes left-sided weakness or paralysis. Unlike left hemisphere strokes, these patients often do not experience speech difficulties. However, they may exhibit neglect, a condition in which they are unaware of their impairments. For example, a patient may ignore their affected limb entirely, increasing the risk of injury. High blood pressure is a major risk factor for hemorrhagic strokes. In some cases, elevated blood pressure may be the cause of the bleed, while in others, it is a response to the brain injury. When blood pressure suddenly drops, it may indicate worsening intracranial bleeding. Monitoring changes in blood pressure is critical when assessing a patient with suspected stroke or brain injury. Several medical conditions can mimic stroke symptoms, making accurate assessment essential. Hypoglycemia, or low blood sugar, can cause confusion, weakness, and even temporary paralysis. Similarly, postictal states following a seizure may resemble stroke symptoms. Subdural and epidural bleeding, due to trauma, can also present with stroke-like deficits. This image illustrates intracranial bleeding. Epidural bleeding occurs between the skull and dura mater, while subdural bleeding occurs beneath the dura, but outside the brain tissue. Both conditions can cause progressive neurological deterioration and require immediate intervention. Differentiating these conditions from stroke is essential for appropriate treatment. A seizure is caused by a sudden surge of electrical activity in the brain, leading to involuntary muscle movements or altered consciousness. Seizures can be generalized, affecting the entire brain, or focal, affecting only one part. Recognizing and managing seizures in the pre-hospital setting is vital to ensuring patient safety and preventing complications. Generalized seizures typically result in unconsciousness and severe muscle twitching. The entire body may convulse for several minutes before the seizure subsides. Some seizures, like absence seizures, involve only brief lapses in awareness without muscle movement. Regardless of type, all seizures require careful monitoring and postictal assessment. Previously called petit mal seizures, absence seizures cause a brief loss of awareness without significant muscle activity. Patients may appear to stare blankly for a few seconds before returning to normal. These seizures are most common in children and are often misinterpreted as daydreaming or inattentiveness. Focal onset aware seizures do not cause a loss of consciousness. Instead, patients may experience unusual sensations, such as tingling, visual distortions, or changes in taste and smell. Some may have localized muscle twitching or temporary paralysis. Focal onset, impaired awareness seizures cause altered mental status, often originating in the temporal lobe. Symptoms may include repetitive behaviors like lip smacking, blinking, or isolated jerking. Some patients experience visual hallucinations or an overwhelming sense of fear. Some patients experience an aura before a seizure, which acts as an early warning sign. Auras can include visual disturbances, hallucinations, unusual smells or tastes, or a sudden wave of fear. Not every seizure is preceded by an aura, and not every patient with epilepsy experiences them. However, for those who do, an aura can provide a crucial moment to prepare for the seizure and minimize injury. A generalized seizure often begins with a sudden loss of consciousness, followed by uncontrolled muscle movement. The patient may exhibit rapid, repetitive contractions of the muscles, known as tonic-clonic activity. During this phase, they may become apneic, meaning they temporarily stop breathing. Seizures usually last less than 5 minutes, but their severity depends on the underlying cause. After the seizure ends, the patient enters a recovery phase called the postictal state. Absence seizures, formerly known as petit mal seizures, are brief episodes of impaired consciousness. Patients may suddenly stop moving, stare blankly, and fail to respond to their surroundings. These seizures typically last only a few seconds, and the patient has no memory of the event. Unlike generalized seizures, absence seizures do not involve convulsions or loss of muscle control. Seizures that last longer than 5 minutes are considered a medical emergency and are likely to progress into status epilepticus. This condition is characterized by prolonged seizure activity or repeated seizures without the patient regaining consciousness. Status epilepticus can lead to severe brain damage, respiratory failure, or even death. As an EMT, immediate intervention, including airway management, oxygenation, and rapid transport, is critical. Seizures can have many causes, including congenital disorders like epilepsy, head trauma, or stroke. Some metabolic conditions, such as hypoglycemia or electrolyte imbalances, can also trigger seizures. Additionally, infections like meningitis or high fevers, especially in children, can lead to seizure activity. Seizures may also result from poisoning, drug or alcohol withdrawal, or brain tumors. Certain medications, when taken incorrectly or stopped suddenly, can also cause seizure activity. Identifying the underlying cause of a seizure is essential for providing appropriate treatment and preventing future episodes. As EMTs, it's important to recognize a seizure when it occurs and determine whether the episode is different from the patient's typical seizures. Some patients may enter a postictal state after a seizure, characterized by confusion, fatigue, and muscle weakness. Recognizing the postictal phase is key to avoiding misdiagnosis and ensuring proper care. Following a seizure, the body begins to recover in a period known as the postictal state. During this phase, the patient may be drowsy, confused, or disoriented. Some experience temporary weakness, known as Todd's paralysis, affecting one side of the body. This condition usually resolves within a few minutes to hours. If a patient does not improve, consider other medical conditions that may be responsible for their altered mental status. Seizures are sometimes mistaken for syncope, which is a temporary loss of consciousness due to insufficient blood flow to the brain. Unlike seizures, fainting episodes typically occur when a person is standing and are not followed by a postictal state. Understanding the difference between syncope and seizure activity helps determine the correct course of action in the field. Altered mental status, or AMS, is one of the most common neurologic emergencies encountered in EMS. A patient with AMS may be disoriented, confused, or completely unresponsive. Causes of AMS vary widely and can include stroke, seizures, infection, intoxication, or trauma. Some cases require immediate intervention to prevent deterioration. Several conditions can lead to altered mental status, including hypoglycemia, hypoxia, intoxication, drug overdose, and delirium. Patients with diabetes are particularly at risk for AMS due to rapid changes in blood glucose levels. Identifying reversible causes is critical for effective treatment. Other possible causes include brain infections, body temperature abnormalities, and brain tumors. Overdose and poisoning can also impair consciousness. A thorough assessment of the patient's history, surroundings, and vital signs is necessary to determine the cause of AMS. When responding to a patient with suspected neurologic impairment, scene safety is a top priority. Look for hazards such as weapons, drugs, or environmental dangers. Quickly assess whether the condition is medical or trauma-related and take standard precautions. If there is a risk of spinal injury, apply spinal motion restriction protocols. Early recognition of potential threats ensures a safe and efficient response. During the primary assessment, focus on identifying and treating life-threatening conditions. Conduct a rapid exam to assess the patient's level of consciousness, airway, breathing, and circulation. Establish priorities of care based on findings. If the patient has an altered mental status, protect their airway and provide oxygen therapy as needed. Gathering a thorough history is essential when evaluating a neurologic emergency. If the patient is unresponsive, obtain information from family members, bystanders, or medical alert devices. Look for evidence of trauma, medications, or other factors that may contribute to AMS. A sample history, assessing symptoms, allergies, medications, past medical history, last oral intake, and events leading up to the emergency, can provide valuable clues. A detailed secondary assessment should include vital signs and a neurologic evaluation. Increased intracranial pressure from a stroke or head injury can lead to slow, irregular respirations and changes in pupil size. If AMS is present, check blood glucose levels to rule out hypoglycemia. Stroke assessment tools help evaluate the patient's neurological function. These include the Cincinnati Pre-Hospital Stroke Scale, the Los Angeles Pre-Hospital Stroke Screen, and the BFAST mnemonic. The Glasgow Coma Scale, GCS, provides an objective measure of consciousness, and is useful for tracking changes in neurologic status. Using stroke scales, EMTs assess facial droop, arm weakness, and speech abnormalities. The presence of one or more of these signs significantly increases the likelihood of stroke. Early recognition and rapid transport to a stroke center are essential for timely treatment. The BFAST mnemonic stands for balance, eyes, face, arms, speech, and time. It expands on traditional stroke assessments by including sudden loss of balance and visual disturbances, both of which are common early signs of stroke. The Los Angeles Pre-Hospital Stroke Screen considers risk factors such as age, history of stroke or seizures, and symptom onset. A comprehensive assessment helps differentiate stroke from other conditions that mimic its symptoms. The 3-item stroke severity scale, also known as the LAG scale, evaluates the level of consciousness, arm movement, and gaze abnormalities. This scale helps estimate stroke severity and guides treatment decisions. All patients with an altered mental status should have a Glasgow Coma Scale, GCS, score calculated. The GCS measures eye-opening response, verbal response, and motor response, providing a standardized way to assess consciousness. Once the secondary assessment is complete, EMTs must continually reassess the patient for changes in neurological status. Comparing baseline findings with updated assessments allows early detection of deterioration. Reassessment is a crucial step in managing patients with neurologic emergencies. Continuously monitor the patient's airway, breathing, and circulation, as well as their level of consciousness and neurological status. Watch for changes in pulse, blood pressure, and respiratory rate, as these can indicate worsening conditions. If transporting a stroke patient, provide ongoing updates to the receiving hospital so they can prepare for immediate treatment upon arrival. For patients with a suspected stroke, emergency department physicians will use imaging, such as a CT scan, to determine whether bleeding is present in the brain. If no bleeding is found, the patient may be a candidate for clot-dissolving medications, which can significantly improve outcomes if given within the treatment window. As EMTs, we must determine the last time the patient was seen without symptoms, as this information is vital for hospital staff in deciding treatment options. Seizure patients require thorough assessment and supportive care. If the patient is actively seizing, ensure their safety by preventing further injury, maintaining a clear airway, and providing oxygen as needed. Avoid restraining the patient during convulsions. If there is suspected head or neck trauma, apply spinal motion restriction. Once the seizure stops, monitor for postictal confusion and transport the patient for further evaluation. For patients experiencing prolonged seizures, known as status epilepticus, immediate intervention is required. Airway management is a priority, and if the patient is not breathing adequately, provide positive pressure ventilations with a bag valve mask. If available, rendezvous with an ALS unit for advanced airway management and medication administration. Rapid transport to a hospital is essential. Most headaches are not emergencies, but there are red flags to watch for. Patients with a sudden, severe headache, especially one described as the worst of their life, may be experiencing a hemorrhagic stroke. Headaches associated with fever, seizures, altered mental status, or recent trauma require immediate medical attention. As an EMT, assess the patient's neurological status carefully and provide rapid transport if necessary. Migraines can cause intense pain and sensitivity to light and sound. If there are no signs of a more serious condition, treatment focuses on comfort. High-flow oxygen may help relieve symptoms in some patients. Creating a dark, quiet environment in the ambulance can reduce discomfort. Avoid using lights and sirens during transport unless absolutely necessary, as they can worsen migraine symptoms. Stroke management begins with ensuring adequate airway, breathing, and circulation. Oxygen therapy is not routinely recommended unless the patient is in respiratory distress or is hypoxic, with an SpO2 level below 94%. If possible, transport the patient to a designated stroke center, where they can receive specialized care, such as clot-dissolving therapy or endovascular procedures. When arriving on the scene of a seizure, the patient may still be actively seizing or may be in the postictal state. If the seizure is ongoing, protect the patient from harm and ensure an open airway. Avoid placing objects in the patient's mouth, as this can cause injury. Provide high-flow oxygen and be prepared to assist with ventilation if needed. Some patients with a history of seizures may refuse transport after the seizure ends. If this occurs, contact medical control and follow local protocols. If the patient has had multiple seizures, is experiencing prolonged confusion, or has another underlying medical condition, strongly encourage transport for further evaluation. For patients with altered mental status, determining the cause is key to providing the right treatment. If trauma is suspected, apply spinal motion restriction. Assess for possible causes such as hypoxia, hypoglycemia, stroke, or overdose. Provide airway and ventilation support as needed, and transport the patient to the appropriate facility for further evaluation.